Hi class, this week we're doing a case study on lactose intolerance.
Diagnosing lactose intolerance, how PAs can facilitate breastfeeding.
Let's read the case study. A 32-year-old first-time mother gave birth to a full-term, healthy girl following an uneventful pregnancy and a spontaneous, complicated vaginal delivery. Prior to delivery, the mother, who had a graduate degree and had attended prenatal classes, completed a breastfeeding course, and indicated via a questionnaire that she was confident about her intention to breastfeed for 12 to 18 months. She was taking maternity leave and had an encouraging support system, including her spouse, family, and friends. 17 minutes after her delivery, she had sustained skin-to-skin contact with her newborn and began breastfeeding. This contact continued for 2 hours. So to quickly summarize, healthy mom, healthy baby. In further conversation, 4 weeks post-delivery, the mother reported that the baby was gassy, uncomfortable, and difficult to feed. She also noted that the baby had a sore bottom with blisters from stool. 2 days later, the infant's pediatrician diagnosed lactose intolerance and immediately placed her exclusively on a soy-based formula. The mother stated that she was bummed out for not being able to breastfeed, but was relieved that her daughter's symptoms improved within a week of being switched to the formula.
Let's dissect this case study just a little bit further. After a healthy pregnancy, uncomplicated birth, and being able to breastfeed for about 1 month, the baby then developed complications related to GI upset and skin irritation. The pediatrician then swiftly diagnosed lactose intolerance.
Now I'm going to talk about the absorption of lactose and the pathophysiology of lactose intolerance.
Lactose is a disaccharide composed of a monosaccharide of glucose and a monosaccharide of galactose. This disaccharide is primarily found in milk and dairy products. Lactose metabolism occurs in the small intestine, and involves enzymatic hydrolysis to cleave the disaccharide into monosaccharides for absorption. The enzyme lactase is in charge of this hydrolysis. Since lactase is required to break down lactose into its smaller components, in individuals with lactose intolerance, insufficient lactase activity prevents this breakdown, leaving lactose undigested. What happens in lactose intolerance? Well, what happens is an incomplete digestion of lactose. Now the unabsorbed lactose moves to the large intestine. This is when the gut bacteria have a little party. They love sugar and they love to eat sugar. And when they eat the sugar, then they ferment the sugar. And this leads to the production of lactic acid and gases such as hydrogen, methane, and carbon dioxide. This fermentation process also causes the characteristic symptoms of lactose intolerance.
Symptoms of lactose intolerance are going to include bloating caused by gas production during bacterial fermentation of the undigested lactose in the colon, abdominal pain and cramping due to the gas buildup and increased internal pressure, diarrhea. The undigested lactose will draw water into the intestine, leading to loose, watery stool. Flatulence results from the fermentation of the lactose by the gut bacteria, producing hydrogen, methane, and carbon dioxide, as we already mentioned. And finally, nausea. In some cases, especially when large amount of lactose is consumed, it causes nausea. Time for a brain break. Here are a couple funny memes I found about lactose intolerance. Enjoy. All right, moving on. Getting back to the case study, let's go back and take a look at those symptoms that the infant was having. She was gassy, uncomfortable, difficult to feed, and had blisters from stool. What do you think? Are those symptoms alone enough to diagnose lactose intolerance in this infant? Maybe. There's actually some tests that the pediatrician for some reason didn't conduct that I want to talk about next. There are 3 types of tests: an elimination test, a blood test, and a breath test. An elimination DIY test just is as simple as that. Stop drinking or eating the lactose products. Then we have the standard lactose tolerance test. This is a blood test that checks for glucose levels after 30 minutes and after 60 minutes of consuming 50 grams of lactose. The blood will then be analyzed for any lactose malabsorption.
A hydrogen breath test checks for lactose intolerance by measuring hydrogen levels in your breath after drinking a lactose solution. It works by first you breathe into a device to get a baseline hydrogen level, then you drink a liquid that contains lactose, then over the next 2 to 3 hours you'll give breath samples at regular intervals. If your body cannot break down the lactose, bacteria in your gut will ferment it, producing hydrogen gas. This gas then enters your bloodstream and is exhaled.
Now that we've gone over the 3 main types of tests to test for lactose intolerance, what about in infants? I feel like the breath test would be hard. I feel the blood test would be a little bit hard. So DIY elimination essentially is what the pediatrician did, just to switch to soy milk pretty much right away. But are there other ways that we can approach this case so that it both benefits the baby and the mother, and it's more catered towards infants themselves?
The answer to that question is yes. The discussion section of this case study does go on to explore a couple of possibilities related to the mother's milk supply that could contribute to symptoms resembling lactose intolerance.
The discussion section mentions that maternal oversupply of milk or overreactive ejection could also lead to the complications and GI upset that the baby was experiencing. Why is this important? Even though this case study revolves around the malabsorption of lactose, the discussion section does point out that to be a well-rounded provider, especially a PA, it is important to explore all options that have led to a diagnosis that causes this GI upset. For the pediatrician in this case, it may have been very obvious that lactose intolerance was the underlying condition. However, if there was a different condition, such as a disruption in the milk production, it will be important to explore all options so that the mother could have continued to breastfeed as she had intended in the beginning of the case.
Oversupply symptoms do include fussiness and gassiness in the infant. The management of oversupply is with implementing short and frequent feedings. If improvement does not occur within 1 to 2 weeks of starting breastfeeding management, further workup may be proceeded.
So there you have it. In conclusion, maybe the pediatrician should have approached this case first by addressing any milk supply problems, and then with a strong differential, it being lactose intolerance. Whereas in this case, the pediatrician jumped right into lactose intolerance, and the mother was a little upset about this. Breastfeeding exclusively for the first 6 months of life, if possible, is endorsed by many health organizations, including the American Academy of Family Physicians, the American Academy of Pediatrics, the American College of Nurse Midwives, the American College of Obstetricians and Gynecologists, the American Didactic Association, and finally the Association of Women's Health and Obstetric and Neonate Nurses. In conclusion, for all of us who aspire to become clinicians one day, running through this case study does 2 things for us. First, it talks about lactose intolerance in infancy, which then educates the reader about malabsorption in the GI. And second, it also underscores the need for providers to explore all options that may be causing specific symptoms, as the most obvious might not be the correct diagnosis, and running through proper tests are likely required for an accurate diagnosis. I hope you enjoyed this case study analysis, and have a great day.